Good morning. I'm Dr. Howard Zucker, New York State's Health Commissioner, and welcome to today's briefing. Joining me today is Mr. Michael Dowling, the CEO of Northwell Health, to my left, and Dr. David Rich, the President of Mount Sinai Hospital, to my right. We are here today to talk about our nursing home report, and we will cover everything in detail. But before delving into the technical aspects of anything, whether it is public health and science or other areas, I believe it is wise to put things into context. So for a few moments, let me do that first. Almost every day for more than 3 months, I joined Governor Cuomo's daily briefings. And as he would say, today is Monday, and we have much to speak about today. Before my time in public service, I worked as an anesthesiologist, as a pediatric cardiologist, and I ran an intensive care unit for many years right here in New York City. I am all too familiar with the pain, the heartache, the agony of illness, of all ages. The thousands of images are indelibly etched into my memory. The public health has been introduced to words, though second nature to me, they were new to them: intubation, ventilation, BiPAP. And they've had to grapple with the fear of a virus, something we cannot see as it wreaks havoc on people's lives. And I know it has taken away way too many lives, young and old, previously healthy, and those who are ill. Every day I read the vignettes section in the paper where they tell the stories of just a handful of those lives lost. And it took the lives of the most vulnerable, those in nursing homes. It is heartbreaking, and I do feel for those families very much. I know what it is to have someone who is frail. My father died last year in his late 90s at home, and I watched firsthand what it is like to be at that end of the life curve. For the relatives of loved ones in nursing homes who died, my heart goes out to you, to everyone in your families, because between the concerns of your mom and dad and your sister or brother and the daily disruptions of how COVID-19 has affected your immediate family, along with the isolation and the uncertainty, I do get it. So when the rise in deaths in the nursing homes happen, I asked myself, as the public health leader, as a scientist, as a doctor in me, and most importantly, even as the son of someone who had a loss recently, I kept asking, what happened? What happened? And it's important to know why, because it matters. It matters for New York. It matters for the nation. It matters to prevent behaviors from repeating themselves. And it matters to bring closure to families, all those families. And just as when in clinical medicine I asked why when someone died, I asked our team to find the answers here. And in medicine, I would delve into the data, the procedures, the information, the steps. It's just how I'm wired. And so we did the same here. But it's important to remember that sometimes what happens is that a narrative gets perpetuated when it's not based on facts. And that narrative, that story gets swept away as the truth, simply by virtue of repetition, whether because of lack of critical thinking or because of malice. Either way, it does not do us as a society any good. So now let's talk about the facts. I'm going to give you some background. COVID-19 has significantly changed how we live, not just in New York, but around the world. This pandemic has rapidly and dramatically altered our everyday lives, introducing social distancing and face mask wearing, school and business closures, and access restrictions to hospitals and other congregate facilities. New York has had 100,000 nursing home residents housed in 613 facilities statewide. New York has had more nursing home residents than any state in the nation, despite being the fourth most populous. Let me just go back. Congregate settings, nursing homes are particularly vulnerable to infectious diseases such as COVID-19. This has been a challenge nationwide since the very beginning of this crisis. The first known COVID-19 positive nursing home residents was identified in Kirkland, Washington in February of 2020. From the beginning, New York State Department of Health undertook aggressive steps to prepare healthcare facilities, including nursing homes, to prevent and control the spread of COVID-19. New York sent over 8.5 million pieces of PPE to the nursing homes around the state. We issued infection control guidance for healthcare facilities, generally and specifically nursing home guidance. We mandated staff temperature checks, face mask use. We canceled group activities within nursing homes, and we suspended nursing home visitation statewide. The purpose of all these actions was to limit the opportunities for nursing home residents to be exposed to COVID-19. We know that despite our best efforts, COVID continued to spread in nursing homes nationwide. From those early days in February through June 26, the virus has infected more than 282,000 people at 12,000 long-term care facilities across the nation. 54,000 residents and staff at these facilities have died from COVID-19. And while, and that's a New York Times article showing those facts. And while the New York Times analysis found that in terms of the percentage of total deaths in nursing homes, New York State ranked 46th in the nation, meaning that 45 states had a greater percentage of fatalities. And even though our per capita nursing home death rate was lower than many other states, we still lost thousands of New Yorkers living in nursing homes. So what happened? We needed to know. So New York State undertook an in-depth analysis of self-reported nursing home data to answer this important question. My department looked at this, and I want to go through that. Just as a summary of findings, we found, and then we'll go through the details, the employee infections were related to the larger community spread, and employee transmission has the strongest correlation to nursing home fatalities. Admission policies were not a significant factor in nursing home fatalities, and data suggests that nursing home quality is not a factor in mortality from COVID. So what happened? How did COVID-19 enter the nursing home? So let's look at the three possibilities. There's the staff, there's the admissions, there's quality. First, we could begin with staff. As the governor has said many times, healthcare workers are the heroes of this pandemic. Whether working in hospitals, in nursing homes, on ambulances, the list goes on. The nursing home staff are incredibly hardworking. They are professionals, all of them. They are dedicated to the residents that they care for. And to care for those who are so frail really does take a special kind of heart. As with other healthcare professionals, many worked right up to the point when their symptoms were evident. Given what we now know about this virus, that shedding can peak before symptom onset, this dedication may have inadvertently led to unintended consequences. Most nursing home residents don't leave the facility very often. Remember, these are their homes, their familiar surroundings, particularly those who are challenged with cognitive issues, memory deficits. These congregate settings allow for frequent mixing for socialization of residents, something that normally has emotional benefits, but allows for rapid disease transmission. We see this in all types of congregate settings, in schools, in dormitories, in group homes. But unique to nursing homes is that many residents never really travel off the premises. So we asked ourselves, how then did COVID come to them? So to answer that, we asked the nursing home administrators to tell us the first date that staff experienced symptoms typical of COVID or received a positive test result. We also asked them to quantify how many staff either tested positive or experienced symptoms of COVID. So what does the data show? So a retrospective analysis shows that the earliest recorded staff illness with symptoms similar to COVID was actually at the end of February, February 24th, if you want an exact date. Let's think about that for a minute, okay? The period of time from infection, from the time the virus is in your body to symptoms, is 2 to 14 days. So if you count backwards from them, this could in many cases bring us back to mid-February when the exposures likely occurred. So is that possible? Well, just last week, Mount Sinai shared their data on their antibody study, which showed that COVID-19 was in New York as early as February 1st. And I know Dr. Rich will speak to this afterwards. But back then, we weren't even testing for it. We actually didn't even have a test. CDC was the only place that a specimen could be evaluated, and for a long time afterwards. In fact, our own Wadsworth Center Laboratory developed the first test for COVID, and that was actually on February 29th. That was the first in the nation, the first test outside of CDC. Back then, we were not even screening for symptoms yet. For the largest number of nursing homes, the first instance of staff reporting COVID-related illness was actually March 16th, as one sees in the peak on that yellow line there, right in front of us. One may ask, well, why does that matter? So let me explain. Because nursing home residents' fatalities peaked on April 8th. You'll see that on the blue line there. Now, April 8th, if you look at the calendar, is actually 23 days after the peak in the nursing homes, first infections among the staff. And that's what the yellow line and the blue line show. That's the 23 days. So one may say, well, why does that matter? Because multiple publications out of the Imperial College of London, other prestigious research institutions have shown that among people in the general population who died from COVID, the average span of time from infection to death was 18 to 25 days. And remember that showed a 23-day period. I want to be clear on this. This is not to place blame at all on nursing home staff or resident fatalities. That's not what we're here to do. We're here to look at the science, try to figure out the answers and the data. Sorry. We need to look at this from that moment in time, not from an analysis using knowledge we have subsequently gained in the months since that time. We have to go back to that point in time. So let's stand at that moment in time. What was the landscape then? Many of the COVID-positive nursing home staff were actually asymptomatic. And as just mentioned, testing was not available then. And let's just say, for argument's sake, that there was testing and that they knew they had it, but they did not have symptoms. There was limited testing, and there were no symptoms that they may have known. The extent to which asymptomatic individuals could transmit the disease was just not fully known in March. And on March 16th, a CDC memo said that symptomatic healthcare workers could return to work 3 days after symptoms had resolved and 1 week from initial symptoms. But it did not address the return to work for asymptomatic healthcare workers. And this is not to be critical of CDC either. They, we, everyone did not know. It was a new virus. It is a new virus. And we are learning more each day. Now, let's just return to the nursing home staff. They were hit hard by COVID-19. So why do I say that? By mid-May, nursing homes had reported 37,000 affected staff. In fact, when I learned about this statistic, I actually said to my team that told me this, I said, you mean 3,700? And they said, no, 37,000. And I was just absolutely shocked by that number. I even remember where I was. I was standing there in my office holding a granola bar, looking down at a textbook of medicine by Harrison's, reading something on immunology. I so vividly remember that moment because 37,000 is an unbelievable number. And we have 158,000 people who work in nursing homes in New York. So this is approximately 24% of the nursing home workforce. Now, interestingly, an independent antibody testing done by a bioreference lab in May showed that the 3,500 nursing home employees that they tested, they found that 29% of them had COVID antibodies. And this is very consistent with our finding. So extrapolating the data to the whole nursing home workforce means that approximately 1 in 4, 1 in 3 nursing home workers had COVID or been exposed to COVID based on antibodies. So you see, as the governor has repeated many times over the past 4 months, and I said this at the beginning, facts matter, and those are the facts. So data about the staff in nursing homes tells us part of the story. And as I said before, there are 3 possibilities. So what about visitors? So this is hard to assess because we don't have all the critical facts here, and they are more amorphous, and we are left to surmise. But I think it's important to say that up front. We know that nursing home residents are representative of all of society. So deductive logic would say that visitors could also inadvertently bring the virus into the facility right back then at a time when we did not know about the potency of this virus. Remember, this was all happening. As I said before, we have to stand at that moment in time and think about this. And when the fog of war against a biological enemy can unfortunately create casualties. So now let's turn to the admissions and readmissions to the nursing homes from the hospitals, the third possibility. And it goes without saying, but I will mention anyway, most nursing home residents, they're frail. We know that. Their bodies have weathered the test of time. The slightest challenge to their physiology can be catastrophic. They don't bounce back so easily, or they don't bounce back at all. We have all seen this in our lives. This is one of the big challenges that we've had. Disrupting their routine can be detrimental to their health, even so much as sleep patterns, their time for meals. In fact, did you know that just changing your clock on daylight savings time, just doing that can disrupt and have adverse health effects on those who are elderly. So it shows you the fine balance that they are in. I remember when I visited my own grandmother in the nursing home, and I left and I sort of said to myself, she's just not the grandmother that I knew just because of how frail she was, and anything disrupted her health, and even so much as I said about a clock. So balancing the residents' welfare against physical ailments, cognitive deficits, and the effect of transfer trauma, moving a patient from one facility to another facility or from a nursing home to a hospital, bringing them to an unfamiliar environment. This is a challenge to them. The entire healthcare community does what it can to manage nursing home residents' care right there inside the home. And most nursing home patients who went to a hospital during the time that COVID hospitalizations were rising, and the curve that the governor has shown us about as it peaked and moved up to that peak, they went because of progressing respiratory issues, because managing their health at the facility was no longer possible. And with such a fragile population, such a trip to the hospital was made because the care at the home was not an option now, and the care that was needed had to be taken care of at a hospital. We looked at the admissions to the nursing homes. We focused on the period from March 25th to May 8th. And in that period of time, we had 6,326 COVID-positive patients that were admitted to the nursing homes from the hospitals when COVID hospitalizations were rising. So what did we find? And there are a few key facts here, and it's on this curve. The bottom, obviously, is the calendar. The peak in nursing home fatalities was on April 8th, and that's the blue line there. The peak in admissions of COVID-positive hospital patients occurred on April 14th. That's the yellow line. So what is strange about that? Well, if the policy was the direct driver in deaths, that some of the press have reported it to be, then the peak of admissions would precede the peak in deaths. It's just the mathematics, the statistics of it. However, it occurred the other way around. If you see, you'll see that the peak in deaths occurred before the peak in admissions. In fact, when you look at the curve, you will see, as the admissions of residents was increasing, the deaths were decreasing. So one may say, well, why is that important? Well, it goes to the false narrative that has been circulating about regarding that March 25th guidance document. The false narrative is that a resident who had COVID brought it from the hospital to the nursing home. But what we have to be is objective, and the data does not support that. The facts show that 310 nursing homes had patients admitted or readmitted to them. So what about those 310 facilities? 252 of them already had COVID in their facility. It is unfortunate, it is sad, but it is true. 81% already had COVID in the nursing homes, in their nursing home. Those are just the facts. Now, a little more about the March 25th guidance document, which we have said many times, but bears repeating. You know, the document following the March 13th CMS guidance simply said that no resident shall be denied admission solely because of COVID-positive status. It did not say you must admit residents with COVID. Now, I know this seems a little bit like semantics. It's really not. It's the fact that words do matter. No resident shall be denied does not equal must accept. In fact, by state law and regulation, a nursing home could not accept a COVID-positive person unless the nursing home could provide, and I'm going to quote this right now, is, quote, proper isolation and protective procedures and provide adequate care, end quote. So let me see if I can explain this in a personal way. So I have a medical license, and on my license it says that I am licensed to practice medicine and surgery. That's what it says. I know that I'm licensed to do things, but I know that there are things that I can't do, and I would not do. I would not take out your tonsils. I would not replace your hip. What I would do is I would refer you to another physician who can do that. And so without casting any blame, I'm simply saying that if you could not do something, then they should have let us know. And even so, we need to return to the facts. The March 25th guidance was not the driving factor in nursing home deaths. Remember, from what I've said before, COVID-19 was already in the nursing home. As I mentioned a few moments ago, and from innumerable conversations with the hospitals, the vast majority of residents who went to the hospital went because of respiratory issues, invariably COVID, and I'm sure that my esteemed colleagues here can speak more to that fact afterwards. The admissions and readmissions did not introduce COVID into the nursing homes. Next, it is important to address infectivity and how it relates to admissions to nursing homes. This is the world of epidemiology, so let me just walk you through this. Those who became ill from COVID can be contagious starting 2 days before the symptoms appear. So for elderly residents with COVID, subtle symptoms are often difficult to be diagnosed. They're sometimes misattributed just to their own frailty, and people think, oh, maybe it's just this individual is sleeping a little bit more today, and not recognize that those may be the beginning signs of an infection. Remember, with COVID, they were not always transferred to the hospital immediately. It was often not until a few days later that they needed acute care. In those fragile residents, the infectivity clock had already started ticking before symptoms surfaced, and that's a few days before that inevitable transfer occurred. Our data has shown that the median time residents with COVID were in the hospital before admissions to the nursing home was 9 days. So 9 days is an important number, and let me explain to you why. Because the CDC says that after 9 days, the infectivity, the contagiousness of this virus approaches 0. So in lay terms, what we're saying is that by that point in time, the point when the resident is no longer a risk to others, the power of that virus has gone from their body, and they're left to try and heal. So you could think about it as if it were a tornado, right? A tornado comes through, it does its damage, and then afterwards you're really left to clean it up. After 9 days, the virus has left and it's moved on. Now, one may say, well, what about those who did not stay 9 days? So let me address that as well. Now, remember what I mentioned about the fact that we do not rush to transfer nursing home residents to the hospital, and what I mentioned about people with COVID being ill 2 days before symptoms appearing. So we are really speaking about more time, perhaps 11, 12 days, maybe even more, from the moment that virus entered their bodies and when they were admitted to a nursing home. And there's data out there about how long somebody who doesn't come from a nursing home, but just in general, who gets admitted to a hospital. I know Dr. Rich could comment about that. But what I'm saying is that they are not infectious. They are not contagious anymore. And as for the nursing home patients who were readmitted, I want to just emphasize again that they were coming from nursing homes where, sadly, the virus had already taken hold. Perhaps we should think about it this way. Nursing homes do not exist in a vacuum. They are part of the community. They are central to the social fabric of how we care for those who can no longer care for themselves. The people who work there are part of the community too. And so what happens in the community affects the lives of those in the nursing home. What better way to capture this than looking at the curve for fatalities in nursing homes and the curve for fatalities in the general community? The peak is on the exact same day, which is April 8th, the yellow line there. And lastly, I'd like to speak about quality. We analyzed whether nursing homes that had a lower quality rating over the past several years had a higher death rate than nursing homes with a record of higher star ratings. In fact, the mortality rate was higher in 5-star rated facilities, better rated, than it was in the lowest rated facilities. That was 12% mortality in the 5-star versus 7% in the lower rated. So the idea that nursing homes that had a lower quality rating over the past several years had a higher death rate than nursing homes with a higher star rating just does not hold. So in conclusion, what caused nursing home residents to get COVID-19? The data shows that the nursing home residents got COVID from the staff and presumably also from those who visited them. Unfortunately, we did not understand the disease early on. We did not realize how widespread it was within our community, and therefore, it was able to be introduced into a vulnerable population. As best as we could, using the tools that we have, we looked to determine the relationships between timelines, and outcomes, between infectivity and symptomatology, between onset of illness and death. We looked at the facts. As we learned more about COVID-19, about the gene-environment interactions, about the pathophysiology of the disease, and about the immunology as it relates to therapeutics, we will have more facts, but we will always make our decisions based on the latest scientific information that we have available. And one day when things quiet down and travel to Europe resumes, I hope to visit South London with my family, because there is a museum, the Kirkcaldy Testing Museum, which carved in stone over the entrance are the words, "Facts, not opinions." I close by reiterating what I said at the beginning. I admire and I respect all the health professionals across our great state of New York for their dedication and service, for their passion and commitment to caring for so many people in hospitals and nursing homes and ambulances and so many other places. But the work is not over. And I thank the public health specialists in and out of government who continue to work on this pandemic. I publicly would like to thank Governor Cuomo for his amazing leadership in turning the tide in New York and changing the numbers and giving us the numbers that we have today. It is a privilege and honor to work for him. And most notably, I feel for the families. I feel for the families who lost someone. I often think about the sorrow that people have experienced because of their loss. And I hope they find strength in the memories of their loved ones. Because in my heart and my head, I feel that that is the thing that will get us through. It helped me get me through the loss of my father, and I wish this all for all of you as you're struggling with the issues that you deal with right now. And I thank you very much. I'm going to turn the microphone over to Mr. Dowling for some words, and then Dr. Rich.
Yeah, thank you very, very much. Let me first of all say, and it's something that the Commissioner just said, that we've been through a very interesting couple of months, and I also want to compliment all of the people in the healthcare in New York that has done a phenomenal job in dealing with an unbelievably difficult circumstance, and especially all of the staff, the frontline staff, and all of the leadership, because despite some Monday morning quarterbacking by some people at the moment, when you're in the middle of a crisis like we were in and having to deal with it the way we did and succeed like the way we did, I think it has absolutely been an exceptional history over the last number of months. And obviously we have learned a lot, as the Commissioner said. I also want to say special thanks to the Department and to the Commissioner for doing such a detailed study here, looking at all the data, following it day by day through the whole process of this event, and coming up with unbelievably important information. Because there has been a narrative out there and continues to be perpetuated, basically saying X causes Y. The trouble is, of course, is that that is not true. And it goes specifically to 3 points I want to make. One is that the narrative has been, and continues to be, hopefully it will end after today's demonstration of the data, the narrative is that nursing home fatalities were associated with admission policies to nursing homes. In other words, that fatalities in nursing homes were caused by the fact that patients left the hospital and went back into the nursing homes. That does not prove to be factual. That was not correct. That is not what happened, as was clearly demonstrated in the data that Howard just mentioned. The correlation is between what happened with community-wide infection and staff infection were the more prevalent reasons why there were fatalities in nursing homes, but it was not because of a directive on March 25th, and it was not because of patients coming out of hospitals going back into nursing homes. That was not the cause. Second general point is that congregate settings, nursing homes, and fatalities in nursing homes is a nationwide issue. Everybody has been struggling with this. And what is remarkable here, again, contrary to some of the narrative, New York has done exceptionally well in that regard. Percentage of deaths, nursing homes, percentage of total was in New York 21%. And just look at other states. I'll just give a couple. Rhode Island, it was 77%. Minnesota, 77%. Pennsylvania, 68%. Kentucky, 61%. So it's interesting where you see all of the narrative focusing on, oh, look what happened in New York. This is the reason this had happened. Look how bad it was. But when you look at it percentage-wise, New York, as Howard just mentioned in the report, New York was number 46 in the United States. That's an important fact to keep in mind. This is an issue everybody is dealing with. But the reasons why these things occur have to be fully understood, and people should not be jumping to conclusions about A causing B when A does not cause B. The third point I'll just mention is that this is also an international issue. Some statistics from across the world is extraordinary. Everybody's dealing with this. In Ireland, which, as you know, I'm from Ireland, and I've been very close to the Irish health system and has been pretty close to them as they've gone through the process over the last couple of months dealing with COVID. 62% of all deaths occurred in nursing homes in Ireland. In Canada, it's about 82%. In France, it's 51%. In Sweden, it's 49%. New York did exceptionally well, comparatively speaking, to other states and internationally. But the central point of the presentation is that those who claim that nursing home admission policy from hospitals caused the fatalities is not supported by the facts. Definitely not, and many other reasons. And that is something that we should obviously be mindful as we go forward in dealing with this disease over the months ahead, because facts matter, as the governor has said numerous times, and you make policy based on fact, not on assumption and opinion. And I want to say compliments to the department and to Dr. Zucker for focusing so deliberately on this, so hopefully that we can get the actual real information out there so that we can focus on the real things and not suppositions and opinions. And with that, let me stop here, Howard, and David may want to say some words, and then we can go into questions if there are any.
Thank you, Dave.
Thank you, everyone. I would like to begin by, frankly, complimenting our Department of Health. One of the great things about the state of New York is that we have a Department of Health that's driven by science and data, and also, and most importantly, compassion for those of us who live in New York and the lives of New Yorkers. And while it is, of course, tragic how many people we've lost from this disease, and we see how many of them were nursing home residents, I think there are some basic facts, again, to back up what the department has released that I would like to cite for you now. The first is that Mount Sinai scientists published some information last week in a preprint server documenting when they inspected this blood samples that were saved from periods throughout the winter, that we first started seeing antibodies to the virus that causes COVID-19 in the week ending February 23rd. And now that's a very important fact because antibodies occur and are peaking in the bloodstream about 3 weeks after infection occurs. So that was alluded to by Dr. Zucker, but this finding proves that within our New York metropolitan region, that SARS-CoV-2, the virus that causes COVID-19, was circulating in our community in the first week in February. And of course, as we know, as the workers that are working tremendously hard and providing great care in our nursing homes are in our community, it further backs up the Health Commissioner's statements and those of the report related to the prevalence of SARS-CoV-2 in our community. And the second major point is, again, one of basic facts. From the time of exposure to the virus to onset of symptoms is 4 to 5 days. From the onset of symptoms to hospitalization is typically 8 days. And then when we add to that the median duration in New York State of hospitalization prior to discharge and readmission or primary admission to a nursing home, that was 9 days. Adding that together, we come up with a total of 22 days. And as you saw before, that when Dr. Zucker was showing these data, the CDC has demonstrated that after approximately 10 days after symptom onset, infectivity has not been demonstrated. So taking this into account, what we see is that the length of hospital admission after the period where patients were pre-hospital and developing worse symptoms, after the period of incubation of this virus, we see that it provides further data to support the conclusions of that report. Taking this all into account, we know a lot more now in July than we knew at this time that these decisions were being made in March. And despite the fact that the decisions turned out to be excellent ones in retrospect, what we have to do now is think going forward, since we're not done with this disease, how we can continue to enhance the safety and protect our most vulnerable residents in New York State. Thank you.
Thank you, Dr. Rich. I'll open it up to questions. I don't know your names, so just...
Commissioner, how you were arguing that the nursing home admissions policy did not have any role in driving nursing home deaths, or just wasn't a primary cause?
The data shows that this, with the 37,000 nursing home staff, that the infection was in the nursing homes before, and as Dr. Rich just mentioned about timing also, and as I've shown on the slides before about the 9 days from when infectivity essentially reaches 0, means that that would not support, it would not be supported by any readmission or admission.
How do you account for other states that have similar nursing home, a similar policy with nursing home admissions? California, Michigan, having very similar death rates to New York compared to states that didn't, such as Florida.
I'm unclear what you're asking.
ProPublica reported 2 or so weeks ago that states that have similar nursing home admission policies, like Michigan and California, had very similar death rates to New York compared to states that did not have a policy similar to the March 25th order, like Florida.
I mean, I would go back and look at that data, but I could tell you what the data that we have shows is the data shows that this is a result of those who came in to the nursing homes, and as we mentioned before, we have had 22% of our deaths are in the nursing homes, which is essentially the lowest in the nation. Other question?
I just have a general question about the death rate itself. How do you define the death rate? Because there's some confusion about dying because of the virus or dying with the virus.
So that's a very interesting question because, you know, there are those who may be COVID positive and have other medical conditions, and and the cause of death was not because of COVID. And this is something that we will ultimately understand more as time goes on and we get more data points. But there are many times when people end up with an illness and they say they died with X, but that didn't cause them to die from X. And so it could be that there are individuals, and there probably are out there, who are COVID positive, but that wasn't the cause of their demise.
Commissioner, what about...
One second, let me just have the others who have questions. Yes.
Hi, Commissioner. With WCDS News. Just wanted to know, are there still studies taking place now? Is this study and research still continuing on nursing homes?
The report, as I've shared with you, has the data there. We always continue to get as much data as we have, that we can get. And every day we get more information that comes in, but that's the report. And as you can see, that's tracked over a period of time. And I suspect that any information we get going forward will sort of parallel the information that we have at this point. Others? Sure.
Some reporting has pointed towards a lack of PPE in nursing homes as something that drove a large amount of infections. Could all three of you just elaborate a little bit on what the report said about how the lack of PPE in facilities contributed to infections from staff, as you say?
Well, I'll start, and then I will turn to my colleagues here. As I mentioned before, we gave millions and millions of pieces of PPE to those in nursing homes. We have delivered over now 13 million PPE to healthcare facilities and 9 million range for the nursing homes. I think that, and many other efforts we have made to address any of the needs of the nursing homes, including staff, including issues of testing. We have tested essentially all of the residents in all the nursing homes across the state of New York. We have tested twice a week. We tested all the nursing home staff. Now it's down to once a week. It's just a matter of the phase that we're in different parts of the state, but now it's once a week across the state. That is over, it's a million, probably over a million tests that have been done. But Mr. Dowling or Dr. Rich?
Yeah, obviously, there's two things here. I just want to make 2 points on two different issues, interrelated. We obviously know now an awful lot more than we knew back in February. One is that PPE does work. And the earlier you use PPE, the better it is. The more effective it is used, the better it is. The way you cohort patients inside a hospital or any other facility is important. The effectiveness of how people use the masks are important. If there's one thing that comes across in dealing with all of these issues the last couple of months for us, and we had at Northwell more COVID patients than anybody else. It became very, very clear that the effective use of PPE dramatically helps. Now, the second part of the issue I think that you may be relating to is what happens out in the public. Way back when we know now, for example, that this virus was here in the community, as was mentioned by David and others, for quite a while back in February. Community-wide transmission was obviously there, including transmission by asymptomatic people. So the earlier you use PPE in the public, the better. So, for example, going forward, this is why it's so important to make sure that the public continues to wear masks, that we continue to social distance, that we don't congregate inappropriately. So those are the things now we know an awful lot more about than we knew back in February, for example. It doesn't change the data that Dr. Zucker talked about in here, but the proper use of PPE is a lifesaver. It's the prevention part of this whole initiative in dealing with this virus, is the use of social distancing and masks, both for workers in nursing homes and hospitals and other healthcare facilities, as well as the public. Right now, as many of us are talking about all the time, to make sure the public complies with the use of masks and social distancing. That includes workers who are out in the public. As if you bring it in from the public into a facility, and if you have not been masking and doing things on the outside, it only exacerbates when you come on the inside, potentially.
And did you want to add anything?
Just very briefly, that the community of health systems, hospitals, and post-acute care facilities of all types, including nursing homes, have a very long history of collaboration. And all of us, I don't think it's particularly well documented, did what we could in the early part of the crisis to help our partners understand and to improve the education and training. Because there were a limited number of people who were able to train effectively our workers on PPE, and we're taking an entire workforce, tens of thousands of people in our health system, I'm sure even more in Northwell, which is larger, and others in the city. We had to train everyone, and we shared that training and that expertise with our partners in post-acute care, and that as we learn more and we live through this pandemic together, I believe that the safety of the residents in nursing homes and frankly of patients in hospitals and our staff has gradually improved as the stability of PPE supplies has improved and as our training has improved, and frankly as it becomes part of normal operations for people to understand what it means to wear PPE on a regular basis every day. So I'm, for one, optimistic that because of these factors that we see that the use of PPE and the training that enables people to use it properly has improved dramatically over the past months.
Thank you, Dr. Rich. Thank you, Dr. Richardson. Thank you, Mr. Dowling. And thank you all for having the opportunity to allow me to share this report with you. I wish you all that you stay healthy as we move through the summer and into the fall. And thank you. If there are other questions, I'm sure our team can answer them. Thanks.
Commissioner, just one follow-up. If you're saying that, are you implying that a lack of training among nursing home staff was responsible for the spread of the infection in mid-March?
I think, as I said originally, that there's no reason to place blame. If you're going to place blame, I would blame the coronavirus, COVID-19. That's where I would put the blame on all of this. Everyone worked incredibly hard. The healthcare team, whether it's in nursing homes or hospitals, are incredibly dedicated professionals. And as I said, we didn't know. No one knew that this virus was here when it was here. It came from, as we've said, as the governor has mentioned many times, it came from Europe. It was here in New York. The data from the antibody studies and other things confirm that. And the fact of the matter is that they work diligently to care for the patients and the residents in those nursing homes. Thank you.